evening to all the delegates of NICE and today's participant. Let me introduce myself first. I am Joita and I will be moderating the session today. Uh, Currently, I am working as nursing officer in AIMS Kalyani, Department of Pulmonology. And previously, I have worked in pediatric cardiology in AIMS Delhi. I'm also a member of NICE from East Zone, and I'm having a wonderful experience working with them. So many of the participants, as per my knowledge, many of the participants have joined newly in NICE and may have a little difficulty about the functioning of about the knowledge of functioning, how NICE works. So just let me brief a little for 5 minutes what we actually do here. So the Nurses Initiative for Community Empowerment is a program initiated by Indian Society of Emergency and Cardiac Nurses with an aim of empowering nurses to acknowledge their pivotal role in promoting health and well-being, even in the community. Beyond the clinical settings, we aim to reach every nook and corner of the community with a view of supporting them by health education and promotion, screening, preventive services, health advocacy, disaster preparedness, and response. So basically, it is like the farthest corner of the community where the people are not able to reach to healthcare. NICE actually try to bring the healthcare system to that community, to the people of that community. So what we actually do first is, as I say, community outreach. We try to reach as much people we can, and by how we try by and how we just reach them by health education and promotion, capacity building of us, the nurses, who can work as fluently as in community setting as they are working in their clinical setting. Clinical setting is known to all. I mean, we all know where the crash card is, which beds are allocated for the critical patients. But in community, it is totally unknown region for us. To just capacity building means to know their culture, their customs, and treat them and give them health education and promote their health accordingly. Next is collaboration and partnership. That means collaboration and partnership, it may be either with any NGO or the PHC, CHC. We can they already have a treatment regime, they already have an healthcare line for them, and we just try to complement or just try to elevate their healthcare system a bit with our knowledge, with the knowledge of the community. And advocacy and policy influences, of course, it is all channelized for the community and evaluation and researches. Next, as we all are the members of NICE, so we know the benefits of being a member of NICE. That is free and early bird access to NICE webinars, guidance and assistance for research, leadership development program, and faculty training program, as we have all the experts from different region, from the different field from the healthcare system, like in pulmonary medicine, maybe from critical care, maybe from operation theater, maybe just from many people are there who are already working in community. So we can definitely benefit ourselves from their knowledge. Skill development program, of course, it is quite different from clinical setting, as we are interfacing with much more people in community. So please ask your colleagues and friends who are in the same field, in the field of nursing, to join the link. It is already described in the slide, to join our community and empower us. Next, before starting today's session, I just want to remind you all that please be present, please be online throughout the session. You already received the mails. The attendance may be taken at any point of the today's program. So please be present in the throughout the session to get your certificate. And all the participants are requested to keep their mic mute as the session is going on, and we definitely have a query addressal session at the last of our at the last of our session, where all your queries will be addressed. So till then, you can put any kind of query at any point of time at chat box or raise a hand, but all your queries will be addressed later. So now let's introduce our today's guest. I take immense pleasure to introduce today's speaker. She is my colleague and my friend, Mrs. Shampriti Dayan. Ma'am has long experience in clinical field, almost around 5 to 6 years. She completed his education from in the NRS Medical College. She has done BSc Nursing, and currently she is posted in endocrinology and metabolic department in AIMS Kalyani. Previously, she was part in AIMS Raipur also. And attendant training program, as you can see, ma'am has done so many courses on diabetes, nurses upskilling program in diabetes management and by AIMS Jodhpur, insulin training program in AIMS Kalyani, basic education series for type 1 diabetes program is ISPA, and diabetes educator training program by CMC Velo. So without further ado, I would like to hand over the session to Mrs. Sampriti Gayan. Ma'am, you can start now.
Shampriti Gayan, and currently I'm posted in endocrinology department of AIMS Kalyani. And I'm after doing my diabetes educator course, I'm also act as diabetes educator in AIMS Kalyani. So regarding diabetes, regarding how to take insulin, today I hope you will gain some knowledge from here from my topic. So let's start.
Yes, ma'am.
Okay. So let's start with the introduction part. According to the recent census, we have get the information that about 5 million of Indians depends on the insulin therapy for the treatment of diabetes mellitus. That number is huge. 5 millions means 50 lakhs of Indians who are taking insulin. Insulin is only prescribed to them who are having the poor glycemic control. So it is the self-administration technique only patient has to take by themselves. So insulin, how to take, how to store it, how to change the needle, and how to while carrying from one place to another place, how to carry it is very important. Because insulin is an emergency drug, and with high temperature, it will lose its potency. Even without proper insulin technique, the patient having poor glycemic control and it will continue, and the dose of insulin will increase, but the patient will not recover, not control their glycemia. So it is very important for every patient, even for our nurses. It is important to know how to give insulin. We can educate them, we can empower them to take the insulin. So before starting the administration of insulin, I want to enlighten you about the basics of insulin, the basic structure of insulin, so that it will be easier to for our nurses to teach the patient, to educate our patient. So at first, come to the structure of insulin. It is known to everyone that insulin is a peptide hormone, and it is produced by the beta cells of pancreatic islet of Langerhans. It has the 51 amino acids and having two chains. Two chains are A chain and B chain. The A chain consists of 21 amino acids and the B chain consists of 30 amino acids. And next, the formation of insulin. When it is formed in, it is the primitive form is the pre-pro insulin. Then with certain enzyme it converted to the pro insulin, which contain the A chain, B chain, and C peptide chain. And after that, when the regular insulin, human insulin is formed, the C peptide chain is cleaved away from the pro insulin and it forms insulin chain. There is the structure of insulin. You can see This is our A chain, then the C peptide bond, and this is the B chain. This is called proinsulin. And when the insulin form, it's form that this is the A chain and this is the B chain, and this is the bisulfide bond. So what happened in C peptide levels? We have to check for those for some certain patient. Like with the C peptide level, we can diagnose the patient if it is having type 1 diabetes or the type 2 diabetes. How we can diagnose? Like normal C peptide level in our body is 0.5 to 2 nanogram per ml. So in patients who are not having the insulin secretion or insulin production, they are not having the C-peptide chain also. So if it is the C-peptide level is less than 0.5 in nanogram per ml, that means the patient is having absolute insulin deficiency, and that can be diagnosed as type 1 diabetes. But who are having like it is if it is more than 2 nanogram per ml, that denotes that patient is having hyperinsulin secretion or having hyperinsulinoma. But not only the C-peptide is the marker for to diagnose the type 1 diabetes, also other markers like GAD antibody, if it is positive, it is called type 1 diabetes. All other markers are also there. But from the structure of insulin, that C-peptide, with the help of C-peptide, we can differentiate the type 1 and type 2 diabetes. Next, come to the insulin secretion. The secretion mainly divides into two phases. Phase 1, which lasts for 10 minutes, and phase 2, which lasts for 2 hours. In phase 1, what will happen? It will suppress the hepatic glucose production, decrease the glycogenolysis, or decrease the gluconeogenesis. And the phase 2, it lasts for 2 hours, which is the more important. Like when we are consuming the carbohydrate in our meal, that time the blood glucose will be rise, and to suppress the blood glucose level, to normalize the blood glucose level, this time the insulin will be produced from the islets of Langerhans. Next, the effects of insulin. Insulin has lots of mode of action. I will tell only the important one, like the utilization of blood glucose by the cells. This is already known to you all. Like in the cell, in all cell, insulin receptors is there, and there is also the GLUT. GLUT is glucose transporters. So while the glucose in diabetes mellitus, what will happen? The glucose can't enter to the through the GLUT to the cell. So insulin, with the help of insulin receptor only, it can happen. So insulin helps to utilize the blood glucose by the cells, and it also helps in fat storage. And the protein synthesis is also increased by the insulin hormone, and some level of glycogen also can store in the liver and muscle by the insulin hormone. Next, the types of insulin. Initially, it was like in 3 types: bovine, porcine. And now with the advanced DNA technology, some human insulin and analog insulin is available in the market. As per the duration of action, insulin, there are 5 types of insulin. The first one is the rapid acting insulin. The rapid acting insulin are mainly the analogs. I will discuss in my later slide about the analogs also. So, which are the analog? Name of some commonly used analogs in our India is Lispro, Aspart, Glulisin, and the short-acting insulin, which name is regular insulin. It is already everywhere. Regular insulin is available, and hopefully in every hospitals we are using the regular insulin. Some intermediate acting insulin like NPH. Some long-acting insulin is also there. Glargine, with the brand name is Lantus, Degludec, Detemir, Liraglutide. And some premixed insulin is also available. Like premixed are mainly long-acting and intermediate acting. Like with Degludec and Aspart, brand name is Rhizodec. And NPH plus regular insulin, it called premixed insulin or mixed insulin. It can be found in 30 by 70, 25 by 75, and 50 by 50. In 30 by 70, it is 30% regular insulin and 70% of insulin. It is always cloudy in appearance. In whichever insulin in NPH is there, this will be cloudy because NPH itself is cloudy. Even 25-75, it is 25% regular insulin and 75% of 25% of regular insulin and 75% of NPH. Next, in that slides, I have shown that these are analogs, and how the analogs are formed. What are the mode of action? Why it is formed? Next slide, I will discuss that. So, what are the analogs? This is at first it was only human insulin, but for the mode of action, for duration of action, some analogs has been created through the DNA technology. The insulin analogs is an altered form of insulin where the structure is modified to overcome the pharmacokinetics properties of the human insulin. The main advantages of this rapid acting preparation include faster onset of action and shorter duration of action. And some long acting analogs are also there. What will happen? It will delay the onset of action and allow the slow and continuous absorption. Some GLP analogs are also there. Why GLP analogs are important, I will tell. Like GLP-1 analogs is liraglutide. It is also one form of insulin, mainly prescribed subcutaneously. So before going to GLP-1 analogs, we have to know the incretin effect. So what is incretin effect? Incretin effect is the ratio between integrated insulin response to the oral glucose and an isoglycemic IV glucose infusion. That means whenever we are taking IV or oral glucose, that time our insulin, through the incretin hormone, our insulin production will be higher. And it will maintain the balance between the blood glucose level and the cell glucose level. Some insulin incretin hormone are also there, that is GLP-1, that is glucagon-like polypeptide, and GIP, glucose-dependent insulinotropic polypeptide. The patients who are having diabetes, in those patients, there will be decrease in incretin effect. So what will happen when they are consuming the carbohydrate orally or IV? There will no increase in the insulin level in their body. So there is no insulin or less amount of insulin, which will cause increased blood glucose level and which will cause the hyperglycemia. That's how the incretin effect helps in our body glucose mechanism. So GLP-1 analogs like liraglutide, what is the benefit of the GLP-1 analogs? I already told that it enhances the insulin secretion in a glucose-dependent manner. Like it will, your body will again recover to secrete the insulin adequate amount as per your oral consumption of carbohydrate. And GLP-1 receptors will activate, and it also suppresses the elevated glucagon secretion. It will slow or delay the gastric emptying, increase the satiety. While taking the GLP-1 analogs, there will be fullness will be there always in the stomach, so we will not consume that much carbohydrate, whichever was we used to consume in the initial stages of the diabetes mellitus. And modest weight loss will be there. So mainly GLP-1 analogs is prescribed for those patients whose BMI is greater than 35 kg per meter square. And there is also low risk of hypoglycemia, as that liraglutide is long-acting insulin. Next, come to how the analogs has been prepared. Mainly the human insulin is hexamer. So with the technology, it has been converted to the monomer, first dimer, then to the monomer. And the monomer is the short acting or rapid acting analogs, which will act faster than the normal human insulin. And the multihexamer are the long acting analogs like degludec, glargine. Those are made for slow absorption and for the long duration of action. So their long duration of action, how it will help? It will help to cover the 24 hours of the day, and it will helps to not to rise in the blood glucose level. Next, some pharmacokinetics of insulin. Like fast-acting insulin or rapid-acting insulin, how it works, when the onset of action will be there, when the peak will come, how much duration is there, it is demonstrated in that slide. Insulin aspart, which is a first rapid-acting insulin, the onset of action is 16 minutes, the peak will come within 1 hour, and the duration of action will be 5 hours. So the appearance of this insulin aspart is always clear. Then come to the insulin lispro. The onset of action of this insulin is 23 to 27 minutes, and the peak will come within 1 to 2 hours, and the duration is 5 hours. And appearance is clear. Insulin lispro ABC, it is one type of analog. Its onset of action is 15 to 18 minutes, and the peak is 1 to 2 hours, and the duration is 4 hours, and it is also clear. And that aspart and glulicin, these all are the rapid acting insulin. Its onset, glulicin is 0.25 to 5.5 hours, and the peak will come within 0.5 to 1 hours, and the duration is 4 hours, and it is also clear. Then the regular insulin, this regular insulin is the short acting insulin. The onset is within 1 hour, peak is 2 to 4 hours, and its duration is 5 to 8 hours, and it is also clear in appearance. Then come to the NPH. For NPH, the onset of action is 1 to 2 hours, and peak will become 4 to 10 hours, and duration is 14 hours plus. And NPH is the cloudy insulin. And then insulin datamir, it is also onset of action is 3 to 4 hours. It is mainly long acting insulin, and its peak is 6 to 8 hours, and up to it works up to 20 to 24 hours. It is also clear in appearance. Insulin glargine is onset of action 1.5. In our hospital, the insulin glargine we are mostly used as long acting insulin. And there is no peak for insulin, like there is no chances of hypoglycemia comparative to other insulin like insulin lispro and regular insulin. There are chances for hypoglycemia, but in insulin there is no chances of that much hypoglycemia, and it will work for 24 hours, and it is clear in color. Next is the insulin degludec. This is onset of action is 1 hour, and it peak comes within 9 hours, and duration is 42 hours. Degludec is the hormone, the insulin, which can work, which the mode or duration of action is more than 42 hours, and it is also clear in nature. And then our mixture, insulin mixture 50-50, 75-25, and 70-30. It's almost near about same hours it will work, but mixture 70-30, that will work 18 to 24 hours. These all mixtures are, this is premixed insulin, but this is the mainly intermediate acting insulin. And the mixtures are always in cloudy. Why it is cloudy? Because with regular insulin, that NPH will be there. That's why it is cloudy. Only that NPH insulin is usually cloudy. Next, I have shown the various insulin and their duration of action, how they act. Like this rapid acting insulin, lispro, aspart, and glulicin, that mode of action, mode of the peak will come earlier, and it is the shorter duration of action. Then the short acting insulin, that is the regular insulin. So regular insulin, what will it do? It will like peak is come like that, and it will. This is the mode duration of action. Then the intermediate and long, and especially for the glargine, there is. See, you can see that graph. Through that graph, you can see that there is no peak. it will continues to go, and it is continues to maintain our blood glucose level. Next, some factors also affecting the insulin absorption. There are lots of factors. What are those? Like exercise. When we are having any strenuous exercise of a limb, within 1 hour of injection, it will speed our insulin absorption. So it is always advised after taking insulin, at least you have to wait for 1 hour to do the any strenuous exercise. And the local massage, like if you are vigorously rubbing or massaging the injection site, it will speed the absorption. So nowadays it is advisable for not only insulin, for every injection, rubbing is completely banned nowadays. So after taking insulin, do not rub the area, or do not rub, especially vigorously rubbing is completely banned. Then the temperature. Temperature, heat can absorb, it can increase the absorption rate. Like when we are using hot baths soon after injection, it will increase our absorption rate. And cold has the opposite effect. Then site of injection, if we are taking it abdomen, it will works faster rather than the others area. And lipohypertrophy, I will discuss in later this lipohypertrophy. While taking injection in our lipohypertrophied area, it will delays our insulin absorption. Then jet injection or inhaled insulin. This inhaled insulin is not available in our India. We are only using the liquid insulin only. This increase the absorption rate. Then insulin mixture. Insulin means mixture that larger doses delays the insulin action and prolonged duration. When it is the larger dose means when it is like more than 50 unit per in a single dose, it is advised by your physician or someone else or your educators. Like it is always advisable to divide the doses into two separate units. Like if it is 50 unit, then you can divide it to 25. Most of the people is not required 50 unit. Even for 40 unit also, you can divide the dose into 20 and 20 unit, and you can take at a time with the different syringe, or at first with the syringe 20 unit and then again the 20 unit. Or it is not recommended to take more than 40 unit in a single dose. Then the physical status, and that what is this? That suspension insulin must be sufficiently resuspended prior to injection to reduce the variability. Like that premixed insulin, here is a regular insulin and NPH, both are there. So while taking the insulin prior to that, you have to resuspend it. Like you have to mix the insulin within the vial, but not vigorously. Next, come to the international color coding for some insulin. So that short-acting insulin, like regular insulin, it is the always yellow color. You can see one vial and vial or that box, it is always there. There is yellow marks. That means it is regular. Sometimes what it will happen, that the insulin come with the brand name, and it is not possible to know the every brand. So with that color coding, we can identify that it is short-acting or long-acting. The like regular or the short-acting insulin always comes with the yellow color coding. Then the premixed insulin. Premix 3070 is brown color and premix 5050 is gray color. Intermediate acting NPH is always in light green. So not only the color coding, you have to read the name also. It is very important to read the name, but if the brand name it is all not known to us, then we can check with that color coding that it is long acting or short acting. Some long acting insulin like Lantus, it is comes with the purple color, and Ditimir, it is comes with the sea green color. Next, come to the indication to take the insulin. All diabetes, like type 1 diabetes, there is absolute insulin deficiency too. So we have to take the insulin. No type 1 diabetes is any medication, no medication will work on type 1 diabetes. So patient diagnosed with type 1 diagnosed diabetes always recommended to take insulin. Type 2 diabetes with uncontrolled glycemia, patients are usually advised with insulin. But at first, doctors or physician has to try that triple dose therapy. That is like at least we have to try 3 medication at a time. Then if it is not controlled, then only insulin can be prescribed. Then gestational diabetes mellitus. In gestational diabetes mellitus, only the metformin can prescribe. If with metformin, taking metformin, if it is not working, then the patients would advise with insulin. No other medication, oral medication can advise in gestational diabetes mellitus, as it is not safe for pregnancy. Only the biguanide, that is metformin, is safe for pregnancy. Then pancreatic DM. In pancreatic diabetes, this is also called type 3C diabetes. So in type 3C diabetes, it is there is no insulin or less insulin production. So patient always used to have to take insulin. And then LADA. This is another type of diabetes, that is latent autoimmune diabetes in adults. LADA, this diabetes used to come after 5 years of age. At first 3 years, the patient no need of any insulin. Patient will be well controlled with oral medication only. But after the 3 or 4 years, patient will dependent on insulin. That time, patient will be prescribed for insulin. For MODY is the young diabetes only, mature onset diabetes in young. What will happen in MODY? That it will happen less than 25 years of age always. So in MODY, there is no need for insulin, but in some certain cases, wherever other complication has developed, like nephropathy, neuropathy with uncontrolled GM, then only you can prescribe, or your physician can prescribe the insulin. Then the diabetic ketoacidosis. Diabetic ketoacidosis is an emergency situation. What happened in diabetic ketoacidosis? Due to persistent hyperglycemia, that ketone body will store, and it will causes acidic pH, and also Kussmaul breathing, that is the acetone breathing. Acetone breathing will be there. So in such cases, not only subcutaneous insulin is sufficient. In such case, IV insulin should be advised. And IV intravenous insulin you can't give directly. It will be always dissolved with the normal saline and then can infuse to the patient. And the hyperosmolar hyperglycemic non-ketotic syndrome. This is most of similar to diabetic ketoacidosis, but some certain points which is different. Like in this case, the patient is having greater than 600 mg per dl blood glucose, and pH will be also acidic, but there will be no Kussmaul breathing, and ketone for ketone body, but blood test for ketone bodies or urine ketone will be absent. In this case, it is also advised to give IV intravenous insulin infusion. We always recommended to at first you have to dilute it with the normal saline, then you can administer. In the insulin routes, we can give insulin only in subcutaneous or intravenous, but certain insulin we can't give the intravenous. Only the regular insulin is advisable to give subcutaneous or intravenous. Other than the analogs is only for subcutaneous, and NPH also subcutaneous, and even long-acting insulin like Largin, you can't mix with other insulin. It should be always advised to give subcutaneous, never give the intravenous route. Next, types of insulin regimen. Patients with as per their need, insulin regimen you can prescribe. So prescribed insulin regimens are split mix regimen, pre-mixed regimen, bedtime dosing alone, and basal bolus regimen. So split mix regimens is like you have to mix the NPH and the regular insulin. Nowadays, it is not recommended to mix the insulin and to give the patient, because it is complicated a little bit for self-administration of insulin. It is not recommended. And premixed regimen, like premixed insulin, insulin mixture 30-70 and all, you can give to the patient, and it is always like 12 hours apart. Always in premixed regimen, the patient is advised for insulin mixture, 12 unit in the morning time and 12 unit in the night time. It should be always in 12 hours apart. Then bedtime dosing alone. Some patients is having oil control, not oil control, but not that much of high sugar. Also, we can prescribe that bedtime dosing alone. Bedtime dosing alone, in this case, is mainly the long-acting or intermediate-acting insulin should be prescribed. Mainly glargine, NPS, it should be prescribed. Bedtime is at the night, 9 or 10 p.m. A patient is prescribed only one body insulin and the basal bolus regimen. It is basal bolus regimen for mainly type 1 diabetes and for this one with pancreatic diabetes, with doctor physician used to prescribe this basal bolus regimen. In this regimen, both the long acting and the short acting insulin is prescribed. So this is the curve of the basal bolus regimen. Basal regimens is basal insulin will be the long-acting insulin, that is glargine, detanate, degludec, and bolus insulin will be the short or rapid-acting insulin, Lispro, aspart, regular insulin. So what is basal bolus regimen? Basal bolus regimen mimics the normal insulin profile of our pancreas. So in pancreas, what happens? One types of insulin will be always there, which is continuously maintaining our normal blood glucose level for 24 hours. So this basal insulin, long insulin, it will maintain for 24 hours. Like for example, I'm giving that glargine insulin, it is maintained the 24 hours of time and it is maintaining our blood glucose. But we are taking our breakfast, we are taking our lunch and dinner. 3 large meals we are taking in a day. To meet this hyperglycemia, like while we are taking the breakfast, it creates like hyperglycemia. So these sorts of doses we have to give. This is the bolus dose, and our normal pancreas. Then incretin effect I already told that in normal pancreas also it happens. Like while we are taking the food, this time our glycemia level will increase, and with this one, this insulin will also act. So while taking before breakfast, we have to take 1 bolus insulin. Before lunch also we have to give 1 bolus insulin, and before dinner we have to give 1 bolus insulin. This is the basal bolus regimen, and this is our function of our normal pancreas also. Next, before administration of insulin, we have to know about these various devices and gadgets of insulin. Okay. So gadgets and devices we can divide into 3 types, like blood glucose monitoring devices, insulin administration devices, and devices that enhance and improve the daily living. So those are the devices. At first we come to the glucometer. So glucometer, you all know about glucometer. It measures mainly the capillary blood glucose level. So ask your patient always to buy the glucometer with memory button. What happened now? Sometimes you ask the patient to doing one chart, monitoring chart. So what will do patient? Patient will do some false entry. So why every visit you ask your patient to come with the glucometer, and you can cross check with the monitor sheet and the glucometer. It is advisable from our side. Also, every time we advise the patient to buy the glucometer with memory button. And one more important thing is there, like glucose strips. In the manuscript, you can see that manufacturer, as per manufacturer advice, you can see that the strips will be stored within 4 to 30 degrees centigrade. But in summertime in India, that our temperature is more than 30 degrees. In most of the places, like in West Bengal, I'm from West Bengal. So West Bengal, it is always more than 30 degree. Even Delhi, Rajasthan, it is more than 30 degree. So in summertime, it is advisable to keep the strips inside the fridge. Otherwise, it will lose its potency, and it may give the false result. And next come to the CGMS or FGMS. CGMS and FGMS, it is the continuous glucose monitoring system or the flash glucose monitoring system. So here it will have this one is the sensor and one reader. it has to install once, and it will work, and it will give the reading up to 14 days. I'm telling this one like for with hyperglycemia, with type 1, type 2 diabetes who are having insulin therapy, monitoring is very important step. In insulin techniques, monitoring is the another one most important step. So patient has to monitor their blood glucose level. That CGMS is always monitor the interstitial blood glucose, and this glucometer is monitors the capillary blood glucose. So interstitial blood glucose is higher than the capillary glucose, and capillary blood glucose is higher than the venous blood glucose. So while setting in that CGMS reader, we have to set our blood glucose level 80 to 180, and it will shows the alarm, and in every minute it can measure your blood glucose, and once it is installed in your body, it will work for 14 days. So there is no need to prick repeatedly, and there is no pain. Even for installing this one, there will be no pain, because only the there is no needle. It is like chemo port only. There will be only one filament inside your body. You can do your regular walks, everything. You can take bath, and we used to apply one tegadram above this. Already this portion I already discussed with you. Next, come to the another device for administration of insulin. This is the pen device. For pen device, what will be there? This is the pen, and this portion is the needle, and this inside is the inside that pen there will be the cartridge in which the insulin will be there. Okay, so for pen device, some certain points you must have to remember before administering the pen device. That needle should always detach from the pen while keeping in the fridge. What will happen? Like while you this pen, you have to always store it in the inside the refrigerator within 2 to 8 degrees. So what will happen if I am not detaching the needle? I am attaching the needle and I am keeping it in the inside the fridge. So what will happen? Due to cold, that cartridge will create a negative pressure. So with the negative pressure, that outside air will enter into the cartridge while it is when it is cold. So what will happen? There will be the air bubble. When you can see in my picture, there is also one air bubble. So what will be there? That composition will be hampered. Like especially for premixed insulin or NPH insulin, that composition will be hampered and it will lose its potency. Next, when we are moving out the insulin pen from the refrigerator, due to the outside hot weather, that it will create the positive pressure inside the cartridge. So some insulin can moves out of the cartridge, out of the needles. So what will happen again? It will change the ratio of the premixed insulin. And one more another things is there, like for pen device, we need to do the priming. So what is priming? It is a very important step for pen device. For every patient we has to educate, because I have got so many patients with this error. Like before administration of insulin, patients should be advised with dial 2 unit in pen device at first and pushing the amount into the air. If the medicine is coming, if the drops of insulin are coming out, then only it is okay. Most of the time, that plunger and the cartridge end will not touch. So what will happen? It will only deliver the air to the patient. I have got one patient, like he's taking insulin for 1 week, but that end of the cartridge will be here and the plunger is here. So he's taking insulin repeatedly, but it's not going, and he's having very high blood glucose level as per his SMBG chart, and he's telling that I'm taking insulin for last 7 days, but it's not working. My SMBG, my monitoring chart is like same only. Then we our team, we identify that there is a error. So priming is very important for pen device. And what is the importance? I already told you that it will make air-free the pain device and avoid to administer air instead of insulin. That patient, my patient, he was taking only the air for last 7 days. Next, come to the syringe and vials. It is very important, like to match the syringe and vial. So you can see this one. This is 40 IU per ml. So if the insulin is having this one 40 IU per ml, we have to use the 40 units syringe. Okay, we can't mix this one. So syringes are available like 100 unit also. So if the vial is written as 100 IU, and patient has to buy 100 IU syringe instead. Otherwise, the dose calculation will be different and patient can take the other doses. Like in glargine, if we prescribe that 20 units of glargine and patient is taking with this one, so what will happen? The patient is taking the more doses. Like this in 100 IU syringes, the every mark is equal to 2 unit. And in 40 unit syringes, it is only 1 unit. So the patient has to be confirmed before giving the insulin administration technique demonstration. The patient has to always tell about this one, that if your insulin is 40 unit, it is written in your file, you should always buy 40 unit syringe only, not to buy 100 unit. They can buy, like in pharmacy, they can go and they can tell that give us the insulin syringe. The pharmacy, without knowing it, they can give the 100 IU syringe, that but patient is using the 40 IU vial. So it is always check that if it is patient is taking the right dose or not. Next, come to the insulin port or insulin pump. So insulin port, it is the newly invented device in for diabetes control. Like port is same as a chemo port. One port will be there and patient can administer insulin by this port. What is the benefit? Multiple pricking will not be there, and patient can take insulin easily with that port also. But port is not that much cost effective. It is a little bit costly. An insulin pump, it is also very much costly. Most of the that air control insulin pump is almost 5 lakhs for one pump. Insulin pump, there will be a import, and this is the pump. And pump should always kept in the inside a cooling pouch, which will maintain the temperature 2 to 8 degrees. Inside that pump, there will be one vial you can place, and with that vial, you can set the dose of one basal, one bolus, and as per the prescription. And patients who are having an infusion pump, they should always put this one CGMS, continuous glucose monitoring set, with them to monitor their blood glucose. Otherwise, it will or they have to check by themselves with glucometer also. Otherwise, that pump can fail at any time. That is not manually, that is completely AI generated. So it is better to be monitored every time. Next, come to my insulin topics, insulin techniques, how to maintain this one. Everyone is listening or someone sleeping? Hello? Is it,
Yes,
am I
ma'am.
audible?
Yes,
Yes,
audible.
ma'am.
Yes.
Yes, ma'am.
Yes, ma'am. Okay, now I will come to the insulin techniques, the main topic. Is it clear? What I present now, is it clear, Joita?
Yes, ma'am. It's
Okay.
all clear.
Okay. At the end of topic, I will see with the question. Is it clear or not? Okay. Let's go with the, if any query you can ask at the end of the session. Okay. So let's go with the insulin techniques.
If you have already a query, you can text it in the chat box. The questions all will be answered later. You can already you can put the questions in chat box.
Okay, let's start with the insulin techniques. Okay, this is the easiest way to remember the insulin techniques for patient and for us also. That portion denotes Sir Adam. So S denotes storage, I for site, R for rotation, A for administration, D for devices, and A for adjustment of dose, and M for monitoring of blood glucose. These all points we have to maintain while giving the insulin. So at first come to the insulin storage. I already told and everyone knows that insulin vials and pens both should be refrigerated. That's mean between 2 to 8 degrees centigrade, but never frozen. Do not keep the insulin or vials or pen inside the deep freezer, only within 2 to 8 degrees centigrade. And in refrigerator, it should be kept always in the door. Then the unused vial and cartridge. People, what they will do now? They used to buy the vial and cartridge, and they which one they are using, they used to keep it in the fridge, and unused vial they used to keep it like in same corner in their medicine box. But it is not advisable. The unused vial and cartridge, it always should be refrigerated. And avoid extreme temperatures such as direct sunlight, kitchen, luggage bag, and top of the refrigerator or television, because top of refrigerator and television is also like more than 25 degrees centigrade. And once you open your insulin vial or you have started your insulin cartridge, discard the insulin after 28 days. And if it is expiry date, it is there or not, that do not depend on it. Whichever is earlier, like if you have the 28 days of use insulin earlier, then you have to, if it is not finished, you have to discard it, because after 28 days, it will lost its potency. And some other points in our India, so many people, so many patients, they are not having the refrigerator. For there, we have also some solution. Like for they can put their vial in a plastic bag and tie a rubber band and keep it in a wide mouth bottle or earthen piece filled with water. And during the summer, the earthen piece should be kept inside the sand to maintain the temperature. And the earthen pot should be kept in the cool and dark place, and that water inside the earthen pot, it should be changed every second day. Next, the storage while traveling. So when we are traveling by land, we can't carry our refrigerator with us. So there are also some solution. Like we can store it in a flask. Flask means good flask, like Milton flask. And we can keep the ice pack inside this. And in market, cooling pouch is also available. Inside the cooling pouch, there will be the insulin. Sorry, there will be the ice pack there, so we can carry with this one also. Or insulin carrying box is also available in the market. Patient can buy that and they can carry their insulin with that. But always maintain the cold chain. Like more than 25 degree, if it is more than 25 degree, the insulin completely lost its potency. And that patient, what to do? They are taking insulin, and there will be no result, no glycemic control. And always keep the insulin in the handbag, not in the luggage bag. And while traveling by air, always you should carry your extra insulin so that there is no need, like if it is broken or anything happen, then you can take your insulin. And insulin should not be gone through the X-ray machine of the airport. It will lost its potency also. So while going to airport, the patient is always advised that they should carry one physician certificate that they can show to the airport person, that airport authority, that they are having insulin, and they will not gone through the X-ray machine. Next, come to the site of insulin. So many sites are there, but most preferable site is anterior abdominal wall. or else the lateral aspect of anterior abdominal wall during the pregnancy after 28 years, 8 weeks. There are so many misconceptions that during pregnancy you can't keep your insulin in your abdomen, but it is completely misconception. The patient has to take the insulin in the abdomen only. So even in the pregnancy, like in later pregnancy, after 28 weeks of pregnancy, patient can take the lateral aspect of anterior abdominal wall, not the anterior abdominal wall. And upper outer aspect of arm, lateral aspect of thigh and buttocks are also, we can take insulin, but patient is always advised to take insulin in their abdomen only. So site are also has shown in that picture. For abdomen, we have to keep 2 fingers away from the navel because there are less subcutaneous tissue and there are more nerve endings. So we have to space the 2 fingers from the navel. And this upper outer arm, buttocks, and upper outer thigh, we can use as our insulin administration area. Next is the rotation. It is very important, very important. Like rotation of side is very important. So keep 2 fingers away from the navel and divide the injection site into the 4 quadrants or in the half when using the thigh and buttocks. And using 1 quadrant for 7 to 8 doses and moving to another quadrants after that. Every dose should be spaced on 1 inch. And rotation of sites should be audited in every visit and advice to be provided when needed. Avoid injecting into hair roots, scars, small stretch mark, or any skin abnormalities. So this is our abdomen, like this is our navel, and you have to give the injection 2 finger away from the navel. Then divide your abdomen into 4 quadrants. You can use your whole abdomen. Patients are advised to use their whole abdomen, not this side, or this area. So how it will be used? Like this quadrant, you can start from this quadrant. If the first dose is taken here, then next dose is 1 inch spaced, and then again here, here, like that. They have to rotate their injection site. In 1 quadrant, they can take 7 to 8 doses. After finishing 7 to 8 doses, they can come to another quadrant and they can again continue like 7 to 8 doses. Then 7 to 8, then 7 to 8. Like that only. Then again, if it is finished the 4th quadrant, then again start from this quadrant. If the patients are taking only this and this side, there will be the deposition of fat layer. There will be pain, there will be bruises, and it will hamper the insulin absorption. And for thigh and hands, they can divide into 2 portions and they can doing like this and this. But abdomen is always mostly preferable. Only in case of any surgical site is there, but surgical recent surgery is there, then only they can use their thigh and buttocks. Otherwise, they can use their abdomen. And for pregnancy, they can use the lateral area. Lateral area, they can use this portion and this portion. Next, the administration. How to administer the insulin? It should be it is known to everyone that pen or syringe, whatever it is, you have to always take with 90 degree with the 10 steps of insulin administration that I will describe in later slide. Next, the devices. Whichever I described already, they can select as per their affordability and availability. Like for pen device, it is costly, and for this one syringe and vial, it is not that much costly. Patient can afford it easily. Even for glucometer, it is affordable, but the CGMS, it is little bit costly. In market in India, it is like with sensor and reader, it can 11,000. So people can buy that glucometer only with 1,000 or 1,200, like that. Next, come to the adjustment of dose. Adjustment of dose I will not discuss in this session because it is itself a big topic. We, the diabetes educator, can also adjust the dose of insulin as per the patient need and as per the patient condition, and it should be done by a physician also. In our hospital, what we are doing, like it will be prescribed by the physician, but as per the, for especially for type 1 diabetes and all, we can teach the patient how to adjust the dosage also. But it is huge itself, a big topic, so it will be not discussed in my insulin administration technique. Next, it is the monitoring of blood glucose level. So this is one SMBG chart. SMBG is what is SMBG? SMBG is the self monitoring. This is the SMBG, self monitoring of blood glucose chart. We used to give it the patient, whoever is in insulin therapy. So you can see a patient can write their date and then fasting, after breakfast, before lunch, after lunch, before dinner, after dinner. Here we used to prescribe for 4-point SMBG, that is the fasting sugar, blood sugar, then 2 hours after breakfast, 2 hours after lunch, and 2 hours after dinner. And patient also can check infrequent, and they can write what amount of insulin they are taking, how they are adjusting, and all. So a patient is advised or requested to bring that SMBG chart in every visit, along with this glucometer with memory button, so that we can tally with that SMBG chart. So who needs SMBG? Patients with any type of diabetes for prevention of complication. Any pregnant women, they have to do the SMBG. Then the tendency to develop severe ketosis or hypoglycemia. There is some patients there, they have the pattern, like in that they have the pattern like continue post after breakfast, they are having that higher blood glucose level, after lunch they are having the higher blood glucose level. By seeing the SMBG, you can assess the how they are taking their diet and all. Then sometimes is there hypoglycemia unawareness. Generally hypoglycemia should have some symptoms, but sometimes the patient is having without any symptoms. Like this patient is having the before lunch 67, that is hypoglycemia. Less than 70 is called hypoglycemia, but patient is not knowing this one. Sometimes it happens. So to monitor this one when the hypoglycemia is happening, that SMBG is important. And some intensive treatment on insulin pump or insulin injection, it is also important to check the self monitoring of blood glucose. And intensive treatment, like if the patient is admitted here, then SMBG will be monitored by us only, and the healthcare provider. And what I have told, that post-meal blood glucose always should check after 2 hours of consuming your breakfast or consuming your lunch for normal patient. But for GDM, for gestational diabetes, it should always check after 1 hour of meal. And some benefits of SMBG, that it provides the objective feedback on blood glucose. We can see the blood glucose level of the patient. Accurate records of daily blood glucose fluctuation if the blood glucose is fluctuating. And as per SMBG chart, insulin dose can be adjusted. That I have told that is the dose adjustment. What we do, the diabetes educator or the doctors, they have to see the SMBG properly, where it is. Like I'm giving one simple example. If the patient is having that breakfast, before breakfast, after breakfast, this is high, then we can increase the before breakfast insulin level. But this is not only seeing by one day profile. There will be pattern. We have to see the profile. We have to see the SMBG. Then only we can adjust the doses. Then the needle change. That all the needle, like a pen or the syringe, it should be changed every 4 doses in spite of pen device or syringe, whatever it is. Every 4 days, not the 4 days. Every patient, we educate the patient for 4 doses. The patient used to hear that 4 days. No, not 4 days, 4 doses. Why it should be changed in 4 doses? See, this is the microscopic image of needle. This is when we are using the new needle. This is the see the sharpness and see the sharpness. After only one used, the sharpness, this needle become blanket and it will cause painful bruises, tenderness will be there. And after twice use, this will be this, and after 6 times, see, this is the microscopic image of after 6 weeks. As patient, after telling repeatedly that no, you don't use like that, they used to use them. but it is not advisable. Always discard the needle after 4 times use. Then the needle length. So our skin thickness is about 2.2 mm. That is the dermis layer thickness. So average leading length for an insulin administration always recommended to 4 to 6 mm. See, this is the 4 mm needle. So how it is works on patient. So if it is thin patient, then also it comes in the subcutaneous. If it is very obese patient, then also it is come in the subcutaneous layer. But you have to insert the insulin needle always in the 90-degree angle. So it will only come into the subcutaneous. Never it will come to the this one muscle layer. Then needle disposal. For community setup, for in our hospital, we are having the puncture proof container, we can discard that. But for community setup, for educating the patient, you also educate that needle disposal should be proper. Otherwise, it can cause pricking, unnecessary pricking to others. So needles should be collected in a hard tin box or hard plastic box and disposed to municipality as per their rule or nearby health center. In case of it is panchayat area, if they don't have any municipal disposal, they can go to the nearby health center and they can discard the needle there. Next, come to the skin folds, how we have to hold. So skin fold, this is the correct technique. This is the C you have to hold the like that only. And for obese patient, it is not recommended to hold the skin fold. You can insert the insulin. I mean, patient can insert in insulin needle, the 90-degree angle, and they can push. Syringe and vial compatibility, I already have discussed that. For you 100 syringes, you have to, for you 100 IU per ml, and for 40, you have to use the 40 unit syringes. Okay, then for the lipohypertrophy, the patient, sometimes lipoatrophy is also there, like patient is not having the lipid fat layer there. So in that cases, we have to be more careful. As an educator, I used to tell to every patient, and I used to audit my every patient as their abdomen is having lipohypertrophy or what. Otherwise, it will always increase your insulin doses, but there will be no, like you are taking insulin 50 unit, 40 unit, but there will be no improvement of glycemia. So rotation is very important for taking self-administration of insulin. Next, how you will prevent your lipohypertrophy? It is very easy. That rotation, you have to rotate your insulin area, and regular inspection and palpation of insulin sites. Ask the patient and teach them how to inspect, how to palpate the insulin sites, and do not reuse the needles. That blanket needles also cause the lipohypertrophy. Follow the correct rotation policy. Use larger injection surface area, that is abdomen. That's why, that is the another reason why we chose always to take the insulin in the abdomen. Don't take huge dose in a site. It also can cause lipohypertrophy. So if it is huge dose, that is more than 40 units, you also always advisable make it into 2 parts and then give. And don't inject into the lipohypertrophy site. It will not absorb properly, and it will not create any glycemic control. Next, the assessment before any injection. So prior to injection, we have to assess the site that and palpate for lipohypertrophy, and also some things like we have to also assess like for old person, like more than geriatric person or pediatric person also, it is advisable to buy this pen device, because in pen device the leading length is 4 mm, while the this one syringe it is 6 mm. So it is always advisable to take the 4 mm needle and with pen device, and it is easy to, for old persons especially, it is easy to dial the doses, and there is a clicking sound while we are dialing 1 unit, 2 unit in the pen device. There will be clicking sound. If there is any visual acuity disturbance of that patient, they can see that geriatric persons, he can hear by the sound also that he is dialing 1 or 2 unit or what. And inspect for wound, bruises or blisters. Injections should be given in a clean site with clean hands. And before drawing the insulin, before withdrawing the insulin, you have to check the name of insulin, the expiry date, and date of opening of the vial also. And vial and pen device should be gently rolled up for 10 times before giving insulin. Rolled up means you have to mix the insulin, but gentle mixing, because in premixed insulin or NPH or any cloudy appearance, any mixing concentration problem will be there. So you have to always mix it properly, but it is gentle. It should be gentle, not vigorously. And clear insulin should be cleared and cloudy insulin should be cloudy. If there is any precipitation, any cloudy appearance in clear insulin, you have to discard the insulin and you have to take the new insulin. Next, how to roll, it is shown 10 times you have to roll as per the Fit India guideline. Whatever I am telling, that is Fit India guideline. In AIMS Kollani, we are following this one, Fit India guideline, and also in CMC Vellore, from where I did my diabetes educator course, they are also following the Fit India guideline. So it is recommended as per Fit India guideline, before taking insulin, roll it, gentle roll for this one 10 times. Before taking the dose or before dialing the dose, you have to roll up. Then steps of insulin techniques. First, take the insulin out from the fridge at least 30 minutes prior to administration. You are keeping insulin in fridge in 2 to 8 degree centigrade insulin, but you are taking insulin just immediate after taking from the fridge, but it is not recommended. That much chilled insulin will not absorb properly. It will create your constant hyperglycemia or hyperglycemia. So you have to take the insulin from the fridge 30 minutes prior to administration and keep it in the normal area, not above the refrigerator, not above the television area, not any hot area. Then next, before withdrawing the dose, after 30 minutes, you have to check the name of insulin. If you are taking the name whichever is prescribed by your physician, check the expiry date and opening date, and use the syringe. If it is syringe, it is vial, use the syringe according to the strength of the insulin. If it is 40, you have to use 40. If it is 100, you have to use 100. Next is if you are taking cloudy insulin, inspect the insulin for any changes such as any clumping, any frosting, any precipitation. Then roll the vial and cartridge between your palm for at least 10 times, but never shake the vial and cartridge. Step number 4, wipe the top of the insulin vial with alcohol swab and allow it to dry. Then hold the vial upside down slowly and steadily and draw the insulin as per required dose into the syringe. Then the needle should be removed carefully. And if it is pain, dial the actual unit. And by mistakenly, if you dial the wrong unit, like if you are prescribed with 15 unit, but if you dial 16 unit, then just dial it back to 15 unit. Then select the site that should be always in abdomen. Then clean the injection area with an alcohol swab. This is not always recommended. If you are having any visible dust or you are sweating anything, then only you can clean your area. Otherwise, you can take it like that. If you are taking a bath, you have taken a bath, you can take like that. Be sure that the alcohol on the skin is completely dry before you inject. You can't take the insulin above your alcohol swab area, like you have to take there only, but after when it becomes completely dry, then you have to inject. Just wait for 30 seconds, it will be dry. Next is gently hold the skin fold between your thumb and your index finger. Insert the needle at 90-degree angle and slowly push the plunger to inject. Then after immediate, many of patients they used to do after injecting the insulin injection, they used to pull it out, but you have to wait till the 10 count. You have to 10 seconds. You have to wait for 10 seconds. You have to count 10, 1, 2, 3, 4 up to 10 like that, and then only you can withdraw your needle. Do not massage the area. It is not recommended. Then discard the needle as per the proper disposal method. So thank you. It's all about my session today. Any query, anything is there?
Thank you. Thank you so much, Shampiti, for enlightening us with such an informative session. As we all know, all the clinically diagnosed cases are just the tip of the iceberg, right? The big fat portion of this deadly disease is still immersed in the community. And India has already been declared as the diabetes capital, we all know, right? After the session, I personally feel myself more equipped uh, with knowledge to fight diabetes, and I think that all the participants feels the same, right? Before going to questions, I would like to summarize the topic. We have learned about insulin as a drug, its composition, analog, pharmacokinetics, and factors affecting insulin administrations, like temperature, mixture, site of injection, international color coding for different type of insulin, indication, type of insulin regimen like basal bolus regimen, several device and advanced gadgets for insulin administration like pen, port, and pump, the storage and rotation of the site, adjustment of dose, SMBG chart, ma'am has shown nicely. The SMBG chart we are maintaining in AIMS Kalyani, and prevention of lipohypertrophy. Next, we have learned about assessment before injections, all these things.